today's seminar. This is hosted by the College of Public Health and Human Sciences at Oregon State University, and I'm Marie Harvey. I'm the Associate Dean for Research in the college. And I'm pleased to welcome you, and I'm pleased also to introduce Javier Nieto, who's Dean of our college. He will be introducing our speaker, and he'll be moderating this session. So please join me in welcoming Dean Nieto.
Thanks, Marie, and welcome everybody to the research seminar. So it's a great pleasure for me to introduce to you Dr. Stephen Goodman, who is Associate Dean for Clinical and Translational Research and Professor of Medicine and Epidemiology at Stanford Medical School. He's also founder and co-director of the Meta Research Innovation Center of Stanford, the METRICS program, and until recently, he was running the training program in clinical and translational research in the CTSA at Stanford. Steve graduated in the New York University Medical School of Medicine with an MD degree, and then went on to Johns Hopkins, where he obtained a master's in health sciences and biostatistics and a PhD in epidemiology in 1989. I don't know if he remembers, but while he was a graduate student at Hopkins, he was my TA in the Epi Methods class back when I was a graduate student there as well. Before Stanford, he was director of Division of Biostatistics and Bioinformatics in Johns Hopkins Department of Oncology, and he had joint appointments in pediatrics, biostatistics, and epidemiology. His CV is too long and too many academic and research achievements to pay justice just with a quick summary. So I'm going to skip most of that, except for perhaps one notable thing you may know, you may want to know, is that since 1987, he has been associate editor and senior statistical editor of Annals of Internal Medicine. So please join me in welcoming Steve Goodman. Thanks, Steve, for joining us today.
Well, thanks for having me. And I will consider you my supreme success story. If yeah, I didn't remember specifically being your TA. I do remember you being right behind me, and then very soon thereafter, way ahead of me. So so that's the way life is. So you always have to treat your students with great respect, because you never know when you'll be working for them. So that's one of the life lessons I hope all of you learned from that little anecdote. Anyway, I'm going to be talking about testing today. And I will say that this is a talk I've given before on this subject, and I give a course on evaluating diagnostic tests, but I never thought at the time that it would be so much in the news as it is today. So we'll go into that just very briefly. So the title is How Not to Evaluate and Market a Diagnostic Test, a Case Study in Autism. And I hope in looking at this case study that you'll learn a little bit about how to evaluate diagnostic tests, because it's not so easy, actually. But as I said, they are in the news. And in fact, they're in the news almost daily. So just to prove, this is proof of life, you know, you have to show the hostage with the newspaper right next to them of today. So this is today's newspaper. This is today's New York Times. And right there in the center, in testing chaos, some labs drowned while others sat idle. This is just one of innumerable stories about tests that are appearing in the newspaper every day. And there's that story, basically story about how Jennifer Doudna, who created the CRISPR technology, had a lab that was all set up and ready to do, you know, hundreds and thousands of tests, and basically nobody asked her to do them. And just showing you how important in testing, it's not just the technology itself, but it's the whole bureaucracy and delivery around it that's easily as important as the technology. And we're seeing that live. This is the front page of the San Francisco Chronicle today. And if you look carefully, right down there, as restrictions ease, test goals remain unmet. So we see that it's, you know, as we all know, that the testing is absolutely critical to deal with this pandemic. And yet, even after now almost 5 months of heads up, we still don't have our affairs in order. Here's that story blown up. And of course, our president comments on testing almost every day. This is going to be a little soft. I'm going to play you the video from this morning talking about his testing. So here we go. Let's see if it works. You'll have to turn up your volume.
And I tested very positively in another sense. So this morning, yeah, I tested positively toward negative, right? So no, I tested perfectly this morning, meaning I tested negative.
So there you go, complete clarity and test interpretation from the biggest newsmaker in the country. And he's had said some other things about testing. We won't go into those because this is an instructional forum. So here's another piece from the New York Times from Mike Osterholm, who's a very noted epidemiologist from Minnesota. He's really been a fantastic commentator, and he's commenting here on both the fact that there aren't enough, that the ones we have aren't good enough, and some aren't designed to tell us what we really want to know. So now here I have just a few other examples of tests as they're shown in the media. Here we have, and almost every university doing any work these days in the research realm will tell you about new diagnostic tests and new prediction models that they have. What I will say as background is that very, very, very few of these actually turn out to be used in medicine. And there's a reason, and we're going to explore one of those today. So here's another one. Simple eye scan can reveal extent of MS. If one looks at the paper, which we won't, turns out that that's not what this paper was about at all. And this so-called scan and algorithm is not used for this purpose, nor did the authors claim it was. Here's getting into some of the downsides of tests. This is a sort of sad story. Couple does bucket list, ends up broke. It says, fueled by false cancer diagnosis, couple sold home, went on vacation. And they used up all their funds. They used up their 401k, all their retirement funds. They came back and they got the news, the really fantastic news that no, he doesn't have cancer and that he can live a long life. The bad news is that they have no money to live that life with. So this is just one of many consequences, bad consequences when tests are wrong. So I want you to keep this in mind because wrong tests have real consequences, both positive and negative. And that's something that we always have to take into account when we evaluate tests. So what is the goal of a diagnostic or prediction or screening biomarker? And by the way, that's the way these tests are used, either in diagnosis or in prediction or in screening. So what's the goal? So I want you to, if you were sitting in front of me, I would ask you to raise your hands and shout out words, or we'd have a poll anywhere and you would give responses, but I'll give you the responses that other audiences have given when I ask this. And some will say it's to separate the people who are sick from the people who aren't sick. Some people rather cynically would say to make money. Other people would say to help somebody decide something. And it goes on. And all of those are actually very reasonable and not strictly speaking wrong, but they are wrong. That is not the goal. What is the goal? They're not to distinguish between diseased or non-diseased, high and low risk, or to predict. That is not the goal. What is the goal? To do more good than harm. That's the goal. That is to improve overall health outcomes. And I can't tell you how different these two goals are and how important the second one is. I can't emphasize that enough because it's the failure to look at the second and the almost exclusive focus on the first that has led many, many people to pursue these technologies, to start companies. I didn't even show you the Theranos slides, which of course was a big billion-dollar operation here in Silicon Valley that was built on basically built on lies, built on the idea that we could do all sorts of tests based on just on finger sticks, which we cannot do. And it was valued at $9 to $15 billion, and it all collapsed because, in fact, they could not do what they said they could do. But anyway, the focus on whether a test does more good than harm is the most important single thing I want to make sure you come away from this with, details aside. So there you go. Cover the BMJ, do new diagnostic tests. Do they do more harm than good? And this is the question we always have to ask. And then there's another form of harm, which is how much we spend on them. So part of the harm is not just the going on, spending all your money incorrectly or having a misdiagnosis, but literally the billions, hundreds of billions of dollars that we spend on tests that may not increase the prognosis, basically produce health benefit. So that's an issue for our economy as well. So what is a test? Well, it's literally anything we measure. It's anything we measure that's used to guide care in some way. It can be either in a preventive setting, or in a therapeutic setting, like a hospital. So traditional biomarkers like PSA, even BMI can be a test. That is, if you are obese, you are, a BMI over, don't know exactly the threshold these days, 30.5 or 31. You are in a different risk category, and there may be certain medications or interventions that would be recommended to you than if you were below that category. A pregnancy test, that's certainly used to guide care. D-dimer, Oncotype DX, which is a prediction technology used for women with breast cancer. Just measuring the HER2 receptor. If you find that a breast cancer is HER2 positive, that dictates the use of certain therapeutic agents like Herceptin. CT scans, ultrasound, thermography, fecal occult blood tests, Huntington's genes, all these things affect care, and all of them can be regarded as tests. Even a clinical history with signs and symptoms can be evaluated as a test. So it's literally anything that you can measure, but what's critical is that it's used to guide a decision. That it's not just a risk factor, it's not just a number on a page, is that somebody does something on the basis of it, and that what you do has consequences. So it's the doing and the consequences that make these measurements, that elevate them from just risk factor or interesting measurement to test. And that's the framework that we're going to be talking about today. What are they used for? Well, if it's used to diagnose a current disease, it's a diagnostic test. If it's to diagnose a preclinical condition, something that exists before it becomes manifest, that's a screening test. Is it just to diagnose or detect a high-risk state? That could be for any one of the three, screening, prediction, or diagnosis. It can be used to monitor disease activity. That is your diabetes getting worse, like hemoglobin A1C, or is it getting better? It can be used to, this is the danger of having calendar reminders, to predict something in the future or response to therapy. So what we're going to look at is this one test that I stumbled on that was brought to my attention about a year ago or so. That is a blood test for autism. And of course, autism is a very difficult condition for parents and for the people and for the children who suffer from it, and for the adults who suffer from it. So this is a big deal, and let's get into this. So this is yesterday, tweet from a company, NeuroPoint DX. We're going to talk a lot about them. It says, help your patients receive an earlier autism diagnosis. NeuroPoint DX blood test developed for children 18 to 48 months old is a blood panel that identifies metabolic subtypes associated with autism, or ASD, autism spectrum disorders. This tweet appeared yesterday. If you click on that picture, this is what you see. Help your patients receive an earlier autism diagnosis, and you have this absolutely adorable little kid. Maybe he's 18 months old, I'm not sure, but he's definitely there to garner attention and sympathy. So now let's go back and start this story. So the story first became apparent in the news in September of 2018. And it's a company in Madison, Wisconsin, a place that Dr. Nieto knows well. And it says, Madison company study paving the way for an autism blood test, published in a scientific journal. Okay, so this is the paper we're going to actually be looking at. And then just a couple months later, Madison company NeuroPoint DX debuts blood tests for autism. And then you see this instrument, mass spec, to measure the metabolites that this are the basis for this test. So, and this is what's on their website, helping children receive an earlier autism diagnosis. And this is what they say. Earlier diagnosis and intervention can help children with ASD thrive. Behavioral tests can lead to an ASD diagnosis in children as young as 24 months. That is just examining their behavior in certain structured ways. But the average diagnosis is at more than 4 years old. It says our tests can help kids receive a diagnosis and begin treatment sooner. And it says it can be hard to tell if a child is experiencing delayed development that could signal a condition like ASD or is simply developing at a different pace. That's why a biological test, one that's less susceptible to interpretation, could help doctors diagnose children with ASD at a younger age. Our test was developed for children as young as 18 months old. Sounds great. Sounds, wow, terrific. Okay. And there up top, a highly accurate tool to identify 30% of children with ASD that's been rigorously validated in a large clinical study. And if you want to read the publication, you go down here. So we're going to click on that, and this is the publication. I don't know how many clients of this company could even read this title, but here's the title: Amino acid dysregulation metabotypes. Lots of words maybe you've never seen before, particularly metabotypes. Potential biomarkers for diagnosis and individualized treatments for subtypes of autism spectrum disorder. So that is a big ask. Diagnosis and individualized treatment. Wow. So right away, when you see a headline like that, particularly for a disease that we understand very poorly and actually don't really have very good therapies for, the idea that we could tailor these therapies individually on the basis of this, fantastic. This is what it says. The combination of glutamine, glycine, ornithine, amino acid dysregulation metabotypes is identified and is present in 16.7% of CAMP studies subjects. I will tell you what that is. With ASD, that's autism spectrum disorder, and it's detectable with high specificity, 96%, and positive predictive value of 93.5%. within the ASD subject cohort. Sounds fantastic, right? Conclusion: identification and utilization of metabotypes of ASD can lead to actionable metabolic tests. That's the key word, actionable. If it wasn't actionable, we wouldn't care. These are actionable, that support early diagnosis and stratification for targeted therapeutic interventions. So what's the background? Actually, I sort of read you the background already, that most kids develop abnormalities in behavior that can be diagnosed as young as 24 months, but most of these diagnoses come in later, and that it says early diagnosis is important, not only because intensive behavioral therapies are effective, but also because the benefit of early intervention is greater the earlier the intervention is started. Now, I'm not going to go into the evidence base in that here. So what was their study design? So they had three groups. They had an autism group that was defined by the use of this behavioral reference standard called the Autism Diagnostic Observation Schedule, version 2. And this is a structured way of watching kids behave and having them go through various paces that an experienced clinician can use to make an ASD diagnosis. And it takes a while and an expert clinician to administer it. They had children with developmental delay, but without ASD. But they had 94 of those, but they were excluded in the study. And then they had children entering the study who they called TYP. This is called the pathologizing of normality, which stands for typical. That is, they were completely normal kids, completely healthy. And they, in fact, were not routinely administered the same instrument because they were so obviously normal. So they didn't need the instrument. But what they did was they did have some humility here, and they gave them sort of a screening test for ASD, and this was administered to 65 of them. 99 of them were referred for subsequent evaluation, and actually 4 of them received a diagnosis of autism, and 5 received a diagnosis of being normal, a diagnosis of normality. Okay, so this is the actual numbers. So interestingly, they set this up, and I'm not going to go too much into this, because they took a lot of data about metabolism. We're going to look at that in a second, and they created an algorithm out of it. So whenever you create an algorithm out of many, many, many data points, you're sort of shrink wrapping your algorithm to that data. So you want to see not just how well does it predict itself, but how well it predicts independent data. So you can see here we have 2 columns. We have how many autistic kids were in the training set, and then they set aside a separate set of the patients, of the kids, to test out the algorithm that they were saying was going to be the basis for their autism test. So they had 516 total autistic kids and 164 total typical kids, and they divided them roughly 50-50 into training and test set. So you see here, so the vast majority in this cohort were had autism, about 75%. So you see they're predominantly male. This is of the autistic kids. They're 78% were male, the autistic kids, 65% in the normal kids. You will see that the ages of the autistic kids were about 3 years. In the typical kids, about 4 months less. The age range was 18 months to 48 months. And here is the disability quotient. And as you expect, the disability quotient in the autistic kids was average of 62. It's supposed to be 100. And in the typical kids was 100. So that's what you expect to see. That was a developmental quotient. That is, they hadn't reached milestones yet. I'm not going to go through this. This is a very, very detailed, description of how they went through the training set and independent validation. That's not going to be so important. This is going to be important. So what this is amino acid by amino acid, the distribution of that amino acid in the blood in the autistic kids, and those are in red, and the normal kids, and those are in black. So I just want you to forget the blue rectangles for the moment. See these blue rectangles? Forget those. I want you to look at this and just look across the board. Do these distributions look different? So here's glycine. Here's the distribution of glycine in the autistic kids, and here are the kids with autistic spectrum disorder, and here is the distribution in the typical normal kids. Are they very different? I don't think so. Here's the same distribution here. Are these very different? No. Oh, but wait a minute. If you put a box around the very top, what you find is 1, 2, 3, 4, 5, 6 autistic kids and 1, this is serine, 1 normal kid. So they said that this is the indicator for autism. If you have a high level of serine, here it's the opposite for leucine. Down here you see a lot more low leucine levels, and very few of the normal kids have that. So they identified all these as candidates at the high end or at the low end, okay? But the averages were the same. And they continued this. So they did this in the test and training sets, and then they combined them in sort of very complex ways. But at the end of the day, it was this kind of thing that they found. And they developed a very, very complicated algorithm saying, if you are positive in this ratio, this is glycine to isoleucine, glycine to leucine, glycine to valine. If you were positive in any one of these, you were positive. Anyway, it gets quite complicated. I'm not going to go through. And this is actually the final tests that they report, the sensitivity was 17%, the specificity was 96.3%, and the positive predictive value was 93.5%. This was, everything all wrapped up. Okay. So what were their conclusions? He says, and by the way, when we say metabotypes, this is what we're talking about. That is, these are markers of metabolism. And so what they call this fingerprint, whether you're high in one and low in the other, or average or whatever, that is your metabotype. So these are metabotypes based on amino acid levels. These were their conclusions. The amino acid, the metabotypes provide one pathway to much earlier diagnosis of a substantial subset of children with ASD. Earlier diagnosis may also provide the opportunity for earlier biologic intervention. And then it also says stratifying ASD based on metabotypes offers an opportunity to identify efficacious interventions within metabotypes that can lead to more precise and individualized treatment. The hope is that by combining established metabotypes into a more comprehensive diagnostic system, a substantial percentage of children at risk for ASD can be identified at a very early age. And that is, of course, would be very laudable. So I want you to hear, I think this will be a little louder, actually one of the founders of this company, and it was actually a mom who had a kid, describe these same figures. So we're gonna start this, and it's gonna go for about 2 minutes. I'm gonna go to a certain point in the, and you will hear her say these things.
We know that autism can be diagnosed reliably through behaviors at age 24 months, and yet the average age of diagnosis in the country is 4.5. My son was 7. I think we do a little better than that now. But we need to do better than that. And so what can we do with this test? We can diagnose as young as 18 months. And so what we do is screen the child, and then we refer that on to a behavioral specialist. So you still need behavioral assessment because you have to get your ABA therapy, you need to get your insurance, you need to get your IEP. But what hopefully it does is avoid the wait and see, because Johnny's a boy and Susie's a girl and she talks a lot. So that was the first goal. But then we got greedy because we thought, you know what, we can actually do better. We can actually try to understand which thing makes the difference. And if I'm doing modified diet and putting all that effort into it, am I actually choosing the right modified diet? Is it what I'm taking out, or is it what's left that's making a difference? And so we are working on that now in much more in earnest. So who should have our test? We don't think this test should be administered, at least until we have a solution. If it turns out to be like an inborn error of metabolism, and every kid needs to be screened for low branch chains at birth, we'll be talking about a different story. But right now, we think this test is important for kids who are at risk. So that would be kids who have failed an MCHAT, who progressed from a behavioral milestone.
I'm going to move this forward a little bit to later.
Be able to take samples from California. Well, right now in 48 states, California should approve us this month. So we should be able to take samples from California. It's not yet approved in New York. New York is like kind of the biggest stickler for the CLIA lab world, and it'll be probably 2 years before we can take samples from New York. We have had people drive over the river to, either New Jersey or Connecticut to get a test, and this is between you and your God, but it's not uncommon for people to try to seek out a physician that's in a state that can order the test. So all of the forms for requisition and the protocols and everything are on our website, but we encourage you to call us because we want to try to work with you to make sure you don't have to do it twice. So if you decide you want to order the test, we should definitely have a conversation about that. And as I mentioned, it does have to be first of the morning blood. So if you have anything else you want to test that needs first of the morning blood, you could try to do it all at once and then try to avoid, or even urine, try to get it done at one time.
Okay, we're going to stop there. You'll notice that little point she made at the end, which is that the child cannot eat or drink for 12 hours before the test. Now, I don't know how many of you have 18-month-olds or 2-year-olds or 2.5-year-olds, but just try having that child not eat or drink for 12 hours. Just a little thought in terms of test logistics. So this is, let's see. This is the summary that you get if you take one of these tests. You see it says positive patient has metabolic signature associated with ASD. And I'm not going to go, and the guidance, recommend follow-up with neurodevelopmental specialists for further evaluation. Some studies indicate dietary modification may be beneficial for patients with metabolic dysregulation. Okay, and limitations. Test was developed using fasting blood samples. Child who receives a negative result on this test may go on to be diagnosed with ASD. About 30% of children with ASD will receive a positive result. So basically they say it's to be referred to a specialist and maybe they will do another kind of test. So what are the problems with this? Well, I'm going to talk about those. And we felt strongly enough about the problems that we wrote a letter to the editor. And what's interesting is, of course, these days, we got to see that paper before it was formally published, in the sense it was published online. It was a draft online. So we saw that and we commented on that. It was before it was formally published in this journal of, I think it's molecular psychiatry, biological psychiatry. So this was the title of our letter: Lack of Diagnostic Utility of Amino Acid Dysregulation Metabotypes. And what were the issues? Okay, I want to make sure we have time. Good. Well, first of all, you might have noticed that the prevalence of ASD in this study population was 76%. That is 2/3, 3/4 of these kids had ASD. So what does it mean to have a positive predictive value of 93%? So just to be in this, if you just said I was in this study, that's a positive predictive value of 76%. That is, if you say I was in the study, there's a 76% chance you had autism. So this test raised that probability from 76% to 93%. That's what it means to have a positive predictive value of 93%. So all of a sudden, that very high predictive value doesn't look so special. That is, there was already a 76% chance they had it. In the general population, the prevalence in this age group is only around 2%, actually considerably less than that. So if you did this test in them, your chance of having ASD is more like 4% or 5%. It's 18% in the highest risk population, which is high risk SIBS. But even this test, interpreted most generously, you'll see that very generously, would only rise to about 30 or maybe 35%. So remember also who the comparison population was. It was normal kids, not those with developmental concerns. Who do you bring to the doctor to decide on whether your kid is autistic or not? Is it a normal kid? No. In fact, their normal kids were so normal that they didn't even apply the autism test to them. So that's not the kid you bring into the doctor. So in this case, if the specificity drops from 96 to 90%, it would have little value. And if it drops to 83%, that is because they were reporting 17% the false positives, the test becomes literally worthless, because it would produce the same number of false positives as they were detecting with this test. So the average levels of all metabolites were equal between the groups. However, those with autism were more variable in that they had more high and low values. Now, that's hard to explain. So it weakens the plausibility. And interestingly, these amino acids can be affected by diet. So if the autistic kids have a different diet, which they do, they often have food restrictions and obsessions. They only eat certain kinds of foods, or they eat very little, or they eat a lot. You can be measuring diet through these metabotypes, not actually any aspect of metabolism. So, and how do you create more outliers? Well, remember how many more kids there were in the autism population and how few there were in the typical. Well, what happens is if you see more at the extremes if you have a lot more samples. That is, if you only have 100, you're not going to see kids in the 0.1 percentile, but you can here. So you can automatically get the illusion of having more outliers at the extremes, particularly if you're looking at a panel of 40 of these. So you're automatically going to get more of these kids at either at the bottom or the top, which is exactly what they found. So now actually, these aren't even the biggest problems. Everybody in this study was confirmed with a clinical assessment. Everybody. They're giving this test because they're saying that you can detect it before a clinical assessment, but they themselves use clinical assessment as the gold standard. And in fact, on their website, on the report, it says you should be referred for a clinical assessment. So in fact, there is literally zero evidence that this test can detect autism before the clinical assessment can, because every kid in the study was confirmed by clinical assessment. So neither test result eliminated the need for a clinical assessment. That is, by definition, a clinically useless test. That is, if what you will do afterwards is not any different when you test positive or when you test negative, then why do this test? And the final thing we pointed out in our letter was all authors work for the company. Just saying. So they replied, and here was their answer to each of these points. 1, these criticisms are based on a lack of understanding of the state of biomarker research in autism, and specifically on the iterative multi-step process that research on biomarkers must take to establish a diagnostic test. Wasn't exactly responsive, just blather. 2, they pointed to a disclaimer about the positive predictive value and specificity that was not in the online preprint. So let me show you what that was. So this was the original manuscript. It says, taken together, all of these dysregulatory metabotypes identified a altered metabolic phenotype in 16.7% of the autism kids with a specificity of 96.3% and a PPV of 93.5. You'll see the same sentence there. But after we wrote our letter, they added this. We wish to note that our use of PPV was not adjusted for the prevalence of ASD in the general population or for populations at greater risk of ASD. In fact, you don't really adjust for it. You have to show the equation. And if you're starting with a probability of 76%, it shows that this PPV is not very meaningful. The PPV is reported based on the CAMP study population and was used as one facet of the criteria to define metabotypes. We do not imply that a general population screen using AADMs would achieve a similar specificity or PPV. But in fact, because they used normal kids, they were proposing that it be used as a general population screen. Why would you put in normal kids otherwise? But anyway, all of this is added after our letter, and then they responded by saying, oh, we had that in the paper, you must have missed it. But we didn't. Third, diagnostic values were based on the CAMP study population to compare biomarker performance between a training and test set. The focus of our study was to demonstrate the existence of specific metabotypes in the CAMP study population. I literally don't know what it meant. We pointed out that the mean values were the same across everything they measured. It says our approach identifies subpopulations of autism subjects with values not observed in the majority of typically developing subjects. Well, that's true because they took extreme values. Our underlying hypothesis is that subpopulations of autism exist owing to the heterogeneity of underlying biology of ASD. Yes, but they didn't show us any of those populations. So all of this is not in their paper. And finally, actually it's not quite finally, the point that a biomarker-based test would be useful only if it could detect cases at earlier ages than behavioral tests demonstrates a lack of understanding of the current state of autism diagnosis and treatment. Currently, behavioral testing can reliably diagnose children beginning at 24 months of age, but the median diagnosis is 4.3 years. The CAMP study offers the and see how this is phrased. The CAMP study offers the opportunity to assess children as young as 18 months of age. How many of those they actually had is unclear. And as I pointed out before, every single member of this cohort was tested with the standard test. It was a reference standard for all autism subjects. And you'll also remember that the developmental quotient was calculated, and that all by itself was virtually 100% discriminator between the normal kids and these kids. And we made the point that the test doesn't satisfy the first criteria for a decision tool because it doesn't affect subsequent actions. And they said the metabotype-based test panels are not intended to replace the standard of care, but rather to identify children at risk for ASD who can be referred to a specialist for further evaluation. All of these kids who had developmental delay were thought to be at risk for ASD. So it's not clear how they were stratifying those. And were they really saying those who test negative shouldn't be detected? Because they make this point that it misses 70% of those kids. Finally, the final comment made by Sanani and Goodman, that was my colleague who wrote with me, demeans the authors of the letter. They imply that ethical, unbiased research cannot be done through public-private partnerships. And of course, we had done nothing of the sort, but we had pointed out many methodologic problems that all broke in favor of claiming that this was useful when actually methodologically it was shown not to be useful. So interestingly, at the very same time that we wrote this, and this came out right after, there was a blog by a woman named Dorothy Bishop, who I have gotten to know since, who's actually a very, very prominent developmental scientist who specializes in developmental disabilities and epidemiologist in the UK. And she's some very high position in the UK. And she took issue with this test as well. And she picked up something we had not picked up on. And she had looked at the CAMP study because it was registered on clinicaltrials.gov. And let me read you what she found. And we should have found this too. So this is a lesson to you as well. Always look on clinicaltrials.gov, even if it isn't a clinical trial per se. It says the purpose of this trial study is to identify a metabolite signature in blood plasma and or urine to differentiate children with autism spectrum disorder from children with delayed development. Okay? And then going below, Stemina seeks to funding to enroll 1,500 patients. The inclusion of developmentally delayed patients is a novel and important aspect of this proposed study from the perspective of a commercially available diagnostic test. So the defining property of this study was that it was going to be able to distinguish, and this, of course, would be a great achievement, a kid with just, and we'll call it normal delayed development, from a kid with autism in very, very early ages. This would be a great achievement. But in fact, as you might remember, they actually had 94 of these and they excluded them from the paper. So they, in fact, did not do the very comparison that they said was the signature purpose of the study. So here are the key questions that you need to ask about any diagnostic test. First of all, is the intended use clear? Is it to rule in something? Is it to rule out? Is it to avoid or replace the reference standard? I will say if you're going to do the reference standard in all of the subjects that you test, then by definition, your test has no purpose. For whom? When do you do it? And how do you decide on the intervention? None of these were clear here. And the reference standard, as I said, was not avoided. Does the population tested mirror the population for the intended use? What's the answer here? Of course, no. Are the study test logistics the same as in practice, including fasting? Hard to know. They probably was right here, but could you do this in practice? Hard to know. Does the evaluation take into account everything else we know at the time of testing? Well, here we knew that these kids had no developmental delay in the comparison group. So clearly, if they included that, you wouldn't need this test. Will the clinical decision pathway with the test lead to better outcomes than without it? That is, are the interventions known to be effective? And has it shown to perform in a completely different population, not just your population split in two. So that's all I'm going to say about this. I'm going to stop in just a minute. I just want to say something that's really critical for anybody looking at diagnostic, at the evaluation of diagnostic testing, which is that diagnostic studies have phases just like drug studies. You know that there are phase 1 studies and phase 2 studies. Phase 3 studies are usually the randomized controlled trials. Phase 1 is about safety. Phase 4 is about safety as surveillance in the general population. But it's the same thing with diagnostics. The very first stage is how accurate is the test, sensitivity and specificity. Then is test information. That is, how much does it move up or down your suspicion of disease and can it affect decisions? That's phase 2. Then is incremental value. What does it add to what you already know? Then clinical utility. Does it affect health outcomes? And finally, does it provide benefit at what cost? Net benefit at what cost? These are the phases of diagnostic testing that are as clean and as clear as in therapeutic testing. And yet, this is rarely used. We would never say a drug that had been tested just in phase 1 should be used widely, or a vaccine in phase 1. We just heard of eight subjects with a new coronavirus vaccine. We would never say, give it to millions of people. And it's the same thing with diagnostic tests. Sensitivity and specificity are just the first step in a long pathway of development, and they're only phase 1. So just to repeat, the goal of a test is to improve overall health outcomes, that is to do more good than harm. And I hope you've learned a little bit about how not to do that, or how to do that, how not to do that the wrong way, and maybe a little about how to do it the right way today. So there's the applause that you can't give me, but thank you very much. And I hope there are a few questions. It's been a pleasure to be with you.
Well, I can give you an applause, Steve.
Thank you, thank you. See, I had a second thank you just for you.
Yeah, thank you. So at this point, we don't have questions from the audience, as far as I can tell, but I can ask you a couple of ones. I can have a couple of questions.
Sure.
While we wait for others. So I was looking at while you were talking at the journal Biological Psychiatry.
Yes.
It has appears to be one of the top leading journals in the field of psychiatry, with an impact factor of 11.5.
Yes.
I mean, in your experience as an editor in Annals, I mean, this is unbelievable that this paper was published in that kind of a journal. I mean, what does it tell us about peer review and rigor in the editorial process?
Boy, that's an interesting question. So I'll say a couple things. One is diagnostic test studies are singularly and notoriously badly evaluated in the medical literature, because there's not a really clear evaluation framework that most scientists understand. And that's why I added that part at the end. When I teach my course, I don't teach this first, but I teach the stages of development. And unlike drugs, the formal way to evaluate diagnostic tests is not well understood. And in my class, the students, one of many assignments is just go out and find a paper on any diagnostic screening or predictive test and critique it. And what you find is it's very hard for them to find good examples. It's really hard. I mean, I think this one is worse than most, but there's a lot of dust in the air here. There's lots of, the metabotypes, the isoleucine, the different ways they all the different amino acids, and then all the ways they combine them. It's very hard to see right through to the core, which you can see just when you look at the design. So clearly they missed the boat here, ball two, whatever is thrown at them. It does say, not just about this journal, but in many, many, many journals, there are the evaluation of diagnostic tests is extremely poor. There are a couple of guidelines out there, and I would encourage anybody interested in this to go to the Equator website. The Equator is the repository for all the reporting guidelines, and they really tell you how to structure a report and what to look for. And the relevant guideline for diagnostic tests is called STAR-D. And look that up. And there's another one I can't remember right now, Quorum, I believe. I think that's right, but I'm not sure. There's another one, a tripod for predictive technologies. And these tell you what you should be including in a report. Not that many people follow these standards, unfortunately. I would say anybody interested in doing any evaluation of screening or diagnostic or predictive tests should check the Equator website and look for the relevant guidelines for the kinds of technologies that they're evaluating. But this is a widely prevalent problem in the medical literature, certainly not unique to biological psychiatry. And you can find horrendous examples. I mean, they're actually much more the rule than they are the exception in diagnostic testing, sadly.
That's very troubling. So a question from Gloria Cran. It seemed that specificity of the test was very low. Was that not a concern?
Yes. So the so the specificity of the test, particularly in a population of completely normal kids. Remember, these are completely normal kids, and the specificity was, I think it was 96% they were claiming. So 1 out of 25 completely normal kids would be designated as autistic. You can just imagine what the specificity would be in kids who are actually developmentally delayed, who might have abnormal diets, et cetera. So I would say that everything about this was problematic. I mean, I didn't take any of these numbers seriously. And what does it mean to have specificity measured in a population which is of no interest, which will not be subject to this test? People with completely normal tests don't starve their kid and deprive them of water for 12 hours to undergo a blood test for autism. So it's a completely irrelevant number. I mean, that's the ludicrous aspect of this whole thing. And I will tell you, this company is still going on. They charge about $1,000, $800 to $1,000 for this test, a test which doesn't stop you, which effectively tells you nothing.
Are those FDA approved?
So, as you may know, tests don't have to be FDA approved. For providing benefit. Tests are devices, and particularly if they are done in one lab, they are called homebrew tests, or that's the sort of vernacular for them, and they are not subject to FDA regulation at all. The only thing that they have to pass is that they're conducted in a CLIA lab, that is a lab that upholds certain standards. This is actually, I had a few slides on this, but I didn't get into it. Unlike a drug, you don't have to show that any test you propose actually does net good, or even distinguishes between the sick and the well. You just have to show that it measures what it measures. And that's what they could show here. So tests don't have to be approved by the FDA. Just the process of doing the test has to be approved by the FDA. And so you don't have to do a randomized trial or anything to show that it actually accurately separates the properly diagnoses people. So that's a big, and the reason is because homebrew tests are normally under the legislation in the past were thought to be tests that were developed by hospital laboratories, for particular purposes, and hospital laboratories are sort of accountable to the doctors, and they didn't want to be in the business of regulating every single hospital lab in the country. So, but there's been a whole category of companies that have taken advantage of this and said that, in a sense, we're our own lab. And they're not hundreds of labs, it's just one. But if you just send it to that lab, they fall under this, it's called laboratory, the formal name is laboratory developed test. And you don't, as long as you just send it to the lab, that is, you're not sending a kit out to people, that is, you're just sending it to the lab, you don't have to get FDA approval. And interestingly, this distinction was the critical distinction that led to the FDA intervention in Theranos, which collapsed. The Theranos technology, when you were sending blood to Theranos, was not subject to FDA regulation. And that's why they could get as far as they did. They had contracts with Walmart, and I think a huge one with Walgreens. Walgreens, that they were going to have a Theranos booth in every Walgreens, and it was just on the verge of being approved. And this was without FDA approval because they didn't need FDA approval. So how did FDA end up getting involved? Is because they said the little blood container that collected the sample in Walgreens that would be sent to Theranos was the device. And then they said they regulated it. But there has to be a device involved. This one, no device, because you're just sending regular blood to the lab. And so they can completely evade FDA regulation under this homebrew technology, homebrew or laboratory developed test oversight, which is virtually nothing. The FDA has struggled, the people in the device division, to get better control over these tests because these companies are, driving a Mack truck through this loophole, and they haven't been completely successful yet because they run up against, the certain ideology that says companies should be free to do what they do and make the money that they make, and let the market decide. And that's why this company can do what it does virtually unfettered.
Yeah, absolutely horrifying. And one thing in all the genetic testing and the precision medicine approaches to that are becoming so prominent, this is horrifying. I don't know if you have any quick thoughts on that. We have a couple of minutes left.
I do think it's horrifying, and even more so in the genetic testing realm. People need help interpreting these tests.
Mm-hmm.
And if nothing else, even when they're accurate, you need a genetic counselor. You need a partner by your side to interpret them. And we all have heard these stories, and I could have another whole talk just about 23andMe. These results, even when accurate, their interpretation, particularly in the genetic realm, is very, very tricky. And you need a health professional. It doesn't have to be a doctor, but you need a counselor or somebody to help you interpret it, to know what it means. I'll tell you just very, very quickly, one anecdote. The head of 23andMe gave a big talk at Stanford, and somebody stood up, a professor of pathology, and said, "Are you worried about the reports of people who have committed suicide when they've gotten the results of your test?" And her answer was, "We have a little, click box when they order the test that says they've read all of our rules and regulations and the risks. And when they click that box, they know what they're getting into." And that was her answer. So I found that to be an incredibly frightening answer. And I do think the direct marketing of these tests to consumers without any involvement or intervention of a medical professional, and this is separate from the fact that some of them are wildly inaccurate or useless, it is a big problem for exactly this reason. I think it's a public health issue.
Yeah. Well, we are out of time. Thanks, Steve, again for a great talk, and thanks everybody for joining us. We'll be in touch. Stay healthy and well.
And all of you as well.
Okay.
Thank
you
you
very much, everybody.
I'm sorry I couldn't see you in person, everybody.
Yeah, next time.
Okay.
Thanks.
That'd be great.